Hi, this is Adam Glassifer with Info 732 at Drexel University with my final evaluation presentation. Implantable medical device security, a threat to patients, clinicians, and healthcare organizations. Implantable medical devices, or IMDs, are electronic devices that are implanted within the body to treat or monitor certain medical conditions. These include defibrillators, pacemakers, cochlear implants, neurostimulators, and drug delivery systems. There are currently 2.5 million patients in the United States with IMDs, and this number is growing at an exponential rate. Most IMDs are now wirelessly connected to allow for bidirectional communication. Despite this connectivity, there have been no additional security measures added to IMDs, making them very vulnerable to hacker access. Although there have been several studies looking at various access control mechanisms, there have been no widespread adoption or accepted standards put into place. In reviewing the literature, there is substantial background in IMD development and lack of security. Since the first successful implantable cardiac defibrillator, ICD, was placed in 1980, there have been continuous improvements made in design and functionality. At the same time, FDA regulations have not kept up with these advances. The wireless nature of IMDs now allows for the potential to steal protected health information or even control the device. Strong measures must be put into place in preventing unauthorized access control of these devices. One of the main issues seen in the literature is that the inherent nature of IMD design requires a small size. This significantly limits battery capacity, memory, and computing, which makes the addition of security measures quite difficult. Specifically, the battery consideration is paramount concern, as battery changes require a surgical procedure to remove the device, replace the battery, and then reimplant it. In 2011, white hat hackers demonstrated finding an ICD and delivering a fatal shock from 50 feet away, along with finding an insulin pump and fully emptying the reservoir. This demonstrated the capacity for violent acts or terroristic threats to be performed using access to these devices. Additionally, these attacks could be used for financial gain. Some potential solutions reviewed in the literature are potential mitigation techniques that include dual-factor authentication, certificates, near-field communications, biometrics, anomaly detection, and external devices. Previously studied external security devices allow for delegation of security activities to an external device typically worn by the patient to prevent IMD resource drain. By locating these resources externally, their ability to maintain the inherent capacities of the IMD itself and not tax the battery. Other studies have also looked at using authentication servers as a go-between to ensure appropriate access and communication. In designing this evaluation proposal, we paid attention to objectives and stakeholders initially. The objective of this study is that access control is a very real threat to the security of IMDs. However, no unified solution has been adopted to mitigate this risk. The proposed evaluation seeks to provide an evidence-based recommendation for access control security in IMDs by comparing the performance of various previously studied IMD access control security measures. The stakeholders of this evaluation are a far-reaching group. This could affect all those who take part in the continuum of patient care for patients who have IMDs. Stakeholders include patients, physicians, nurses, health systems, insurance companies, government regulatory agencies, and medical device makers. The methods will look at the performance of 5 previously studied and validated IMD access control measures when applied to an implantable cardiac defibrillator. The first device is known as the Shield and has external device-mediated security. Second device is called the cloaker and has token-based security. The third method is the hospital authentication server, which is certificate and permission-based security. We also have the ultrasonic access control system, which is a proximity-based security system. And finally, the biometric-based two-level secure access control, or BBSAC, which is a biometric-based security system. We will take these devices and then employ 5 senior-level white hat hackers from top industry firms who will attempt to gain access to a Medtronic Vizia ICD equipped with each of the measures above and one control, which will have no additional security measures. This will be performed under a variety of scenarios. In active adversary scenarios, a hacker will attempt to gain access to the ICD and send a command to deliver a shock. In passive eavesdropper scenarios, a hacker will attempt to gain access to the ICD communication channel and obtain mock patient information from the ICD. Standard scenarios will be performed using a Medtronic 9790 programmer with standard FCC compliant antennas and powering. Custom scenarios will be performed using a modified Medtronic 9790 programmer with high-powered antennas that are out of compliance with FCC standards. There will be 4 total scenarios we will look at: active standard, active custom, passive standard, and passive custom. Each of these will be performed at distances of 5 feet, 50 feet, 500 feet, and 1 mile. This will mirror face-to-face attacks, close-range attacks, medium-range attacks, and long-range attacks. We will then look at the time to gain access to the device, which will be recorded in seconds. At 2 hours of time, we will consider an attempt to be unsuccessful and will give a score of 0. Each scenario will then be assigned a safety score, which will be calculated by multiplying time and distance. A score of 0 is a perfect score and represents that for the specific scenario listed, the hacker was unable to gain access to the ICD. If the score is not 0, then the higher the score, the more safety thought to be provided by the access control security mechanism. Based upon the overall results from each scenario, the security mechanism with the most SSC equaling 0 will be considered to be the most secure. In the event of multiple mechanisms with the same amount of safety scores equaling 0, the remaining safety scores of these mechanisms will be averaged, and the mechanism with the highest average will be considered to be the most secure. Here is a sample of a data table that we would use for each device and each scenario. As you can see, the device is listed in the top left corner, with each attack scenario listed on the left-hand side of the table. On the right-hand side, we then list out each distance the testing was performed at with the time that it took to access each device underneath. The budget for this proposal comes to a total estimated budget of $240,600. This includes 6 Medtronic Vizia ICDs with an estimated cost of $40,000 each, and 2 Medtronic 9790 programmers at $300 each. We will also need several resources and are assuming that they will donate their time for this study. These resources include access control device research teams, white hat hackers, and an evaluation researcher. We will attempt to partner with an Office of Innovation and Entrepreneurship at a large academic institution for funding. There are several assumptions to this evaluation proposal. We will assume that all proposed IMD access control security mechanisms have minimal resource drain on IMD battery, memory, and computing. We will also assume that all proposed IMD access control security mechanisms function appropriately in emergent situations to allow for immediate access. Some limitations of this study are that there is potential variability among the skill level of recruited white hat hackers. Additionally, there is no previous validated tool to compare the security of different IMD security mechanisms. Also, the safety score system has not been previously validated or used in other studies. In conclusion, IMD security is a legitimate threat to patient safety and privacy, and standardized efforts must be made to improve upon this. Access control security mechanisms offer a potential solution to the problem. Further study is required to evaluate the most secure solution. Further studies should also evaluate high performers from this evaluation in terms of IMD resource usage and emergency performance. Lastly, a qualitative component to additional studies would be extremely useful in gaining both provider and patient feedback on the use of selected mechanisms. Thanks for all your input in this evaluation throughout the course of the class, and I enjoyed learning from all of you. Good luck in your future classes.